Hello, thank you for joining in. My name is Derek, and I'll be presenting on complex trauma stemming from chronic traumatic stressors during early childhood. Complex trauma, sometimes used in the term complex PTSD, is reoccurring traumatic experiences, usually interpersonal and perpetrated by someone with an assumed higher power. There's a wide range of stressors related to complex trauma for children to adults, such as repeated child abuse, oppression, domestic violence, being a victim of trafficking, and those seeking asylum. I will be focusing specifically on complex trauma related to child maltreatment by the caregivers and other significant people, such as uncle, aunt, siblings, family, friends, during the critical years of development, from infancy to about 4 years of age, and the lasting effects trauma has on the brain and body through adulthood. So, what is the impact and scope of developmental trauma? According to the U.S. Department of Health and Human Services, in 2023, the United States alone, there were over 500,000 victims of child abuse. 89% of the victims were abused by one or both parents. Of the 75% of states who reported, about 50% were in households of drug abuse and or domestic violence. Additionally, there are higher rates of complex developmental trauma is trafficked and refugee children. One study published in the European Journal of Psychiatry indicated that about 41% of survivors of modern slavery and human trafficking met the criteria for complex PTSD. Young children in general are arguably the most impacted long-term by chronic stress and maltreatment. This is due to the malleable nature of the brain from newborn age to about 4 years old. During this critical period of development, the brain is forming, and chronic stressors can cause lasting impacts to the neural pathways. Even if a person can't consciously remember what happened to them during this period, the brain remembers their neural connections, creating lasting impacts on behaviors, affects, and thoughts. Our trauma counseling textbook emphasizes this critical period as being significantly involved in cognitive activities such as memories, mindsets, worldviews, and schemas. Chronic trauma during the critical period can affect both the volume and functionality of the brain. The textbook also states that the earlier the trauma occurs, the more profoundly the effects on brain development. The longer the trauma lasts, the worse it is. And the more it is directed personally at a child, the more pervasive the consequences. Effects of complex traumatic stressors during childhood create insecure attachments, emotion dysregulation, dissociation, negative self-perception, unconscious triggers, cognitive functioning issues, and mental health and physical health disorders. The higher the risk factors during the critical period of development that is combined with complex trauma, the greater chances of negative mental and physical health long-term effects. I discussed the impacts of chronic traumatic stressors directed at individuals during early childhood development, but other factors during this developmental period cause lasting effects too. Thus, when combined, there's obviously more chances of greater long-term negative effects. The same risk factors can occur on the individual level and community level, like poverty, low levels of education, negative socialization, and epigenetic changes. Community-based risk factors, however, highlight the frequency and likelihood that long-term negative effects on the brain development occur to a mass amount of people in a given area. I found several research-based studies conducted in several countries from several respected health associations who all found that poverty, lack of education, and violence are contributing risk factors to maladaptive brain functioning and other negative mental and physical health outcomes. If a child is a victim of chronic traumatic stressors perpetrated by the caregiver in addition to experiencing other stressors related to their environment, then the neural pathways creating negative views of themselves, the world, and maladaptive functioning is highly likely. From a theoretical lens, we can look at the modern research and publications from Dr. Julian Ford and Dr. Christine Courtois, who are internationally recognized leaders in the field of trauma research and treatment. They have co-authored and edited several books and research journals. Ford and Courtois draw from attachment theory, developmental psychology, and trauma recovery concepts, and their own findings to describe the uniqueness of complex developmental trauma. They also further developed and expanded the psychiatrist Judith Herman's triphasic model of treatment introduced in 1992 that I will delve deeper in the following slides. Although not recognized in the DSM-5, Ford and Courtois use the term developmental trauma disorder to distinguish complex trauma in early childhood development and differentiate from other disorders such as PTSD and reactive attachment disorder. To categorize the experience of those who develop DTD, Ford and Courtois use several I words to categorize and understand the unique trauma. Think all these words in relation to the caregiver or other significant person in the child's life as the perpetrator of the trauma. Ford and Courtois describe developmental complex trauma as intentional, interpersonal, inescapable, injurious, intimate, intrusive, invasive, identity-altering, and often irreparable. The triphasic model of treatment, first introduced by Judith Herman in her 1992 book, Trauma and Recovery, is a great adaptable framework for children, to adolescents, or adults who have experienced complex developmental trauma. It should be noted that this is not a modality, rather a framework to use as a guideline combined with other treatment modalities such as cognitive behavioral therapy, eye movement desensitization and reprocessing, and narrative exposure therapy. For example, Ford's book Treating Complex Traumatic Disorders in Children and Adolescents and Ford and Courtois' 2020 book Treating Complex Stress Disorders in Adults, that you can see right on the slides, both provides practical treatment modalities to use alongside the three-phase model, along with implementations and adaptations for different stages and trauma histories. The treatment framework is divided into 3 phases. The first phase is to develop the client's personal, relational, and environmental safety. The goal in this phase is for the therapist to build a safe rapport with the client to be safe by learning coping skills, emotion regulation, and psychoeducation regarding trauma and its effects, and addressing any other co-occurring issues. The first phase is often the longest phase because it sets the foundation for the rest of the treatment. Due to the adaptability and not a specific modality, there's not a specific duration of this phase, but instead based on the client's readiness to move on. It's in good practice to be collaborative with the client in the treatment goals, dosage, and provide the client with clear definitions and understandings of each phase, and overall having a non-judgmental, soft approach. Phase 2 is when the trauma processing comes into the treatment. In this phase, the goal is for the client to explore the memories and emotions related to the trauma and past experiences. Second phase of treatment is the reason for needing a highly skilled, trained, and competent therapist. If not approached effectively, the client could be re-traumatized through processing. When the client is guided positively, they can have an understanding of the trauma on themselves and their life and relieve symptoms and stress caused by the complex trauma. As I mentioned, CBT, EMDR, and narrative exposure therapy earlier, this is the phase when those can be integrated. In the final phase, reconnection, it overall aims to empower individuals to lead fulfilling lives beyond their traumatic experiences. In this phase, the client can explore their life aspirations with the therapist. The client could explore new or old hobbies, learn new skills, and take steps towards important goals. They could strive to have more meaningful and fulfilling experiences. This can be through relationships, reconnecting to their self, with greater self-acceptance and confidence. The 3-phase model is highly accepted, utilized, and is an evidence-based treatment, meaning the pros outweigh the cons. A critique of the framework is the long treatment duration. This can lead to higher costs and more time spent in therapy. Additionally, during the second phase of reprocessing, it is possible for the client to be re-traumatized. Again, this is why a need for a competent, well-trained, skilled, and approachable therapist is necessary. However, therapists of this degree are not always available. The 3-phase model can be highly effective when the client's needs are met. The first set of pros are being a gradual intervention, can be tailored to the client's needs, and it is adaptable and a collaborative treatment. The first phase allows the client to become comfortable in therapy environment, building trust in the relationship, and ensures safety. The gradual nature is positive because it allows the client and therapist to gauge the client's needs. In this phase, collaboration can be effective in deciding other appropriate treatment modalities to integrate in the reprocessing phase. Another positive aspect is the focus on the client's stabilization in the first phase by learning and practicing coping skills along with psychoeducation, as the client's safety is of most importance. The model is also positive through its meaning finding approach in the third phase, providing more to the client than discussing their trauma, but promoting growth at the end. Thus, the model is holistic because of these three phases. And finally, it's evidence based and highly accepted in treating complex developmental trauma. Thank you for listening to my presentation. I'll leave you with 5 key ideas from this topic to remember. The first is understanding that from infancy to about 4 years old, the brain is in the critical period of development and it is malleable. Even if we can't consciously remember what happened to us, our brain is aware. That brings us to the next point, that chronic childhood trauma causes permanent changes in the brain development, structure, and functioning. If a person experiences continuous negative experiences during childhood, they'll likely have a negative view on the world and themselves. However, neural pathways can still be created later in life, so more positive experiences can influence positive views on the world and self. Third, added risk factors increase maladaptive symptoms. This is especially during the critical period of development. If you're thinking of developmental complex trauma that I spoke about today, understanding that it is often perpetrated by a significant person in the child's life, and the stressors are intentional, interpersonal, inescapable, injurious, intimate, intrusive, invasive, identity altering, and often irreparable. And finally, with the intervention of the 3-phase model, first, the goal is to stabilize the client and ensure their safety. Then, when the client is ready, to process the trauma. And lastly, the goal is for the client to reconnect themselves and create a more meaningful and fulfilling life. Thank you.